Hello my friends, my name is Ricardo Kern. I'm here to present a series of cases for you that are going to bring a very nice subject, how to treat and how to choose the right approach for aesthetic deficiency peri-implant tissue on the aesthetic zone. So the case that we receive the patients with the implant already in place and you have some problems to treat. And we're going to choose some clinical case as example, and you're going to really go through this clinical case to tell all the small tips, all the small decisions behind the photograph, the small movements that is impossible for us just to show you exactly in small movies or small pictures. And when we try to decide to bring this subject for you, actually it's a common problem that we have, how to proper make the decision of the right technique to treat this kind of problems. And we realize that first of all we need to group similar kinds of deficiency for you to understand that, and after that which kind of solution you're going to apply to each of these cases. So I hope that you enjoyed that you follow the next case, that you share this clinical case also in your social media. That's going to help us to attend or to reach to a larger audience. So first of all, the peri-implant tissue on the aesthetic zone, usually we identify 4 different problems. One of them, and is very common, is a color compromise area. It means that I don't have thickness enough of the soft tissue, maybe not bone, covering that titanium of the implant. Sometimes the abutment itself, it's the problem. And the gray area, by translucency, we can notice this difference in the color of the implant on the surface. So we need to treat that, we need to increase the thickness of the soft tissue to block and avoid this difference of color. Another common problem is the lack of volume or the loss of volume. As you know, for many years when you have the implant in place, according to the way we preserve the socket and immediate implant placement or healed site, as the time passed, we lost some of the volume. And what happened that we don't have the proper emergence profile for this crown. So we need to increase the volume to have my crown exactly with the same emergence profile as a natural crown. Another problem is the position of the zenithal area or the cervical margin of this gingival contour according to the symmetry to the opposite natural tooth. So if I have some recession, some receding of this position, how to correct that. Another part of information that you must pay attention and to collect is the presence of the papilla. If the papilla is filling exactly until the contact point, if this papilla is exactly with the same level to the contralateral papilla, and if you have some recession of the papilla, how we're going to approach to recover this kind of situation. So assuming that we're going to understand exactly these 4 points and you're going to treat that, we need to know some more information to decide which case I can treat and which case I cannot treat doing soft tissue graft. Because of course we know that some problems we must apply also extraction of the implant, and some problems are going to require also bone grafting. So this information is going to help you to decide which case is going to extract the implant, which case is going to need bone grafting. Okay, once there, we're going to just select case that can be fixed just by soft tissue grafting. And first information, and really notice the position of the implant according to the alignment of the crowns, okay? So if you imagine the alignment or imaginary line on the buccal or facial side surface from the crown, this line is a reference for us to have an implant in a good position or unfavored position to try to treat it. Once I have this implant inside this line, to the inner part or to the palate side of this line, we can treat most of the case. But you need to remember that this restorative work is composed by implant and also by abutment and also by crown. So any of these three components may be on the wrong position. So if you have just the crown crossing this line, maybe together with the soft tissue surgery, you need to have some management on this crown. We need to remove this crown, trim, wear this extra volume, or replace this crown for a crown that can be aligned to the natural crowns, okay? Sometimes I have the crown and also the abutment crossing this line. So the management also is going to include the changing of this abutment for a new one position also inside this line. And of course, in some case, I have the implant crossing or buccal placed on this line. In this case, probably on my decision, we ended up to extracting this implant and place a new one, because it's very hard for us to really cover or rebuild the soft tissue when I have the position of this implant too buccally, and usually we have this line as the reference, okay? And of course, it's very important for us to make evaluation of the apical coronal position of the implant platform for some cases that I need to treat, okay? So what happened in which case that this position is very important? Do you remember the 4 kinds of aesthetic problem that we face in the peri-implant tissue? Color, volume, deficiency of the papilla, and recession, okay? Case that I have recession and loss of the papilla usually is going to require that we slip the implant, that we take the crown, take the abutment, use a cover screw for this implant, and we let the soft tissue to be back on the top of this implant. Naturally, or sometimes move a flap over this implant, but we need to let the tissue to be back there, to graft in this position, and just after some time to reopen this implant. And it's very important to make this valuation of the apicoronal position of the implant platform, because as deep as this platform is on this horizontal level, as easier is going to be for you to cover this implant. Sometimes naturally, if the implant is too deep, the tissue is going to cover this implant. But if the platform is too coronally, sometimes even bringing the flap to try to cover, manage it pretty well, the platform is so coronally that the tissue do not handle or stay there for much time. So you have some exposition again of this implant platform. So in this kind of case, we prefer to extract also the implant and replace to the another one. But remember one thing, in cases that I have another problem, like just color change of the soft tissue or deficiency of the volume, but I still have good cervical position and good presence of the papilla. What happened in this case? This case, even if I have the implant platform too coronally, sometimes I can increase the volume without the need to remove this implant. Okay, that is good for us to understand, because I don't like that you apply surgery in a case that you're going to lose the game. So we need to choose exactly which case that we can apply the right approach to really be successful on this recovering. And okay, we're going to choose a clinical case, and you're going to treat a more common problem and an easy one for this starting point. On the next case that I'm going to present to you, you're going to see much more difficult case to handle. And before just moving to this implant, I have to point more to things that we need to be concerned about deciding to treat this implant with soft tissue graft, because there is some situations that I need also to extract this implant. And on this case are when I have more bone loss around this implant than 3 millimeters. Okay, so more than 3 millimeters, you have a long exposition of the neck of this implant, and the environment is not right for me to try to build up the tissue. I need to remove this implant. Another scenario is when I have probing depth equally or more than 6 millimeters around this implant. So it means that I already have a probing depth, a pocket around 6 millimeters, and we are intending to build some deficiencies of the soft tissue. So this is not the right environment, especially in the presence of peri-implantitis. If we cannot treat this peri-implantitis in the 6 millimeters pocket, giving back health to this area, and we intend to graft on top of that, that's not going to work on the long run. So we need also to remove this implant and start a new treatment. But okay, let's assume that I have less than 3 millimeters of bone loss around my implant. So probing depth is less than 6 millimeters. I have a healthy periodontal, and the implant platform is inside the alignment of the tooth, the natural teeth that I have on the surround. So it is a case that I can fix just with soft tissue graft. So in case like this one that I'm seeing here, I have of course deficiency on this emergence profile, because of course the volume of the tissue is not enough. So you will see a very rounded emergence profile for these lateral incisors. We need to augment this tissue with a connective tissue graft to have a natural emergence profile. Another thing is the difference in the color. You see that I can, on the area of the abutment, see a gray color on this soft tissue. If we augment the thickness of this soft tissue to more than 2 millimeters, we can block all the difference in the color from the titanium that goes inside this tissue. So my strategy here is just augmenting the volume. There's no need for me to bring this cervical margin of this tissue more coronally. One small observation for this case is that we're not going to include on the preparation and on the grafting area the mesial papilla. We're going to graft the center of the lateral incisors and a little bit in the distal papilla. As you can see, the distal papilla will have a good position, apical coronally speaking, but we lost a little bit of volume on that area. So I'm going to prepare a little more to the distal margin of these lateral incisors. Okay, good. X-ray valuation. No bone loss around this implant, no peri-implantitis, no pocket on this area, probing a health tissue. I can really work on this environment that is very prone for me to have a good result for my graft. Another thing that I need to know is the 3D position, the palatal buccal position of the implant, the crown, and the abutment. And look at that. Maybe the crown, I have a little bit of over contour of the emergence profile, so we need to fix that. But the abutment and the implant, they are in a good position. I can maintain and keep that in place, okay? So moving forward, we're going to prepare this case now for the surgical approach. We're going to treat this area in different ways to prepare to receive the connective tissue graft, okay? Different ways I talking about to split or to prepare the keratinized area and apical to that the mucosa area. We treat these two different tissues, okay? You can choose to graft this area to go to full thickness flap. This is your option. My option usually is to split this area. What is for and what is against one of these options? Every time that you go to full thickness flap, you're going to let more thickness on the flap. So when you go inside with your connective tissue, usually your flap is more strong and have more chance to survive because you preserve periosteum, all the blood flows on that, and all the tissue arranged and perfect to endure, okay? Once you start to split this area, you can make this tissue a little more weak because you can split this tissue and you can compromise some of the blood flows on this flap, and you increase the risk to have some necrosis on the surface. And if you have some necrosis on the surface, you're going to show the connective tissue under that. If your connective tissue survive, you're going to have some small difference in the static appearance of the tissue that you graft and the surroundings, and we do not want that. So it's not everything in favor of a full thickness flap. Why is that? Because it's very difficult for us to do a full thickness flap in an area like this one, trying to do and contour through this abutment, because the abutment is completely irregular, and do this full thickness flap on the threads that maybe are exposed on the buccal side of this implant. What we decide to do is a splitting, but really a splitting very close to the surface of the abutment, to the surface of the bone, or to the surface of the threads of the implant. We're going to let as much as possible of the thickness on the surface, but you're still going to let some parts of the periosteum on the ground, protecting the bone, nourishing the bones on the threads that you may have some exposition, maintaining and nourishing this bone on the place, and of course maintaining the biologic width around this abutment and around this implant, okay? And if you decide to approach that or to do this kind of surgery, you're going to have two main options to approach a case like this one, okay? So I'm going to show you some options that you may have to treat a case like this one, right? When I face a case like this one, usually what we have is the crown here. When I reach to the border of the soft tissue, this crown is going to have more or less this kind of contour, okay? It's supposed to be a concave contour until I get to the surface of this abutment, okay? This is a stock abutment, so let's design also the implant here, and let's pay attention on our soft tissue. That is the most important part for us to take care of, okay? So here usually is my soft tissue contour, As I have a deficiency of the soft tissue volume, the buccal surface is under the surface of the crown, okay? Is not on this area here. What happens if you try to prepare this area here to receive a connective tissue graft? You're going to struggle a lot to prepare this area exactly close to the abutment, close to the bone, without hurt a lot the entrance and the contour of the soft tissue, once if you're not able to remove the crown to do this preparation. If you can remove the crown, this work here is going to be very easy, and you can do that with a lot of safety to prepare this tissue. But if you cannot remove this crown here, this difference on the contour or this area here of the crown is going to make very difficult for you to turn the blade, your tunneling instruments, to prepare exactly this tissue on the right place. If you are not able to remove the crown from place, maybe you're going to use the second option, that is a lateral approach on this area. So instead of going through the sulcus, you can opt to go to the lateral area, doing a vista incision in apical coronal direction, full thickness, to access this area by lateral approach. Okay, so let's return here, and we're going to exactly do in what I advise you to do, that is access this area through the sulcus. Okay, so we're going to remove this crown, and usually this kind of case requiring that you change a little bit the emergence profile of the crown. So if you're not going to change the crown, you keep the volume, and you're going to diminish the success of covering or success of augmentation of the volume. So you need to take this crown away. So we're going to prepare in the keratinized tissue pretty close to the bone surface, the abutment or the threads of my implant, and we're going to do a swing movement with our blade. What is that? Why is the reason to do this? Because when I start to do splitting, or when I start to do tunneling properly, what I start to do is I advance inside the sulcus with my blade 4 or 5 millimeters, work in one area, and I retreat and reach another area, and I prepare that, and I retreat and go in the middle. What happens when you advance, retreat, advance a lot, is that sometimes you split the tissue in different levels, okay? And it's going to be more difficult for you to connect this area that you advance and retreat. And sometimes you let some parts of the soft tissue still attached from the flap, from the surface to the ground. So you don't have an open and clear space to bring in your connective tissue inside this tunneling area. So if you start to introduce your blade just 2 millimeters, 3 millimeters, and from that swing from one side, return, and just then advance more 2 millimeters and swing again, what is going to do is to prepare this whole area free of attachment of the soft tissue from the ground to the surface. You prepare much better an area to receive the connective tissue that you're going to take inside in a few moments later. Okay, so we have this strategy on the keratinized tissue until I get to the mucogingival line. When I get in the mucogingival line, we're going to change the direction of the blade, and you're going to do the division or the separation of the mucosa from the muscles. So instead of being a deep incision, a deep splitting is very superficial splitting. Sometimes you're going to see your blade working under the mucosa, and by translucency you see the shadow of your blade. It's not a big problem for you to let a thin tissue on the mucosa. Why is that? Because the blood flows is completely different in the position comparing keratinized tissue and mucosa. In mucosa, the blood flows pretty close to the surface. On the keratinized tissue, the blood flows go inside the connective tissue, almost close to the ground, comparing the total thickness of this tissue, because on the keratinized zone you have periosteum connective tissue, a thicker layer of epithelium and keratin. So if you split this tissue in the middle or close to the surface, sometimes you remove all the blood supply for this area. Okay, so in this case, as you are seeing here, we are splitting, also preparing, tunneling the canine, because my graft is going to fill from the mesial part of this lateral until the distal margin of this canine to be tucked under this papilla, exactly the papilla I need a little bit of volume to graft on this area. Okay, so we prepare on the buccal side of this canine full thickness flap, and under the papilla we start to split to connect one tunneling area to the another one. Okay, why all this work on the distal papilla? Because we notice in the beginning that I lack some of the volume that I need on this area. We need to check if I connect properly one area to the another one. Sometimes we get a blunt instrument to check all the way through one side to the another one, to check if I do not have any soft tissue attaching the flap to the ground, if I have really an open space to bring my connective tissue graft. So if it's this size that I need to graft, is exactly this size that I'm going to take a free gingival graft from the palate and promote the deepitalization of this graft, trimming exactly the shape and the size that I need to graft this whole tissue. Okay, we first is going to talk to you about the way we protect the donor site nowadays. The site that I just harvest my connective tissue, we protect with a collagen membrane, we suture that, and over the collagen membrane we lay down a layer of flowable resin, composite flowable resin. Okay, the flowable resin can be attached to the sutures. The flowable resin sometimes can be bonded on the cervical margin of the crowns, and this is by far the best way that you have been treating the donor site from years. Okay, I have tried everything different, and nowadays what gives me for my patients the best post-op more comfort is exactly what we are showing here. In a further video you're going to really bring this technique with the small details. So collagen membrane protected the donor site, and over on the top that flowable resin. Is this way the patient goes from the surgery. After 7 days we're going to remove this flowable resin. Okay, so on the time of the sutures we need to bring and tunneling these sutures inside the area that we just treated. As you can see here, we do not involve the mesial papilla on the grafted area. Why is that? Because I do not need to overgraft this area. And as we don't need to advance the cervical margin coronally, usually we just restrict the area that was tunneling exactly to the size a little larger of my connective tissue. If I need to advance the tissue, I need to enlarge the area that I need to tuning and to treat to allow this movement of the tissue. So here is not a big deal. The only area I need to move a little more coronally is exactly the distal papilla. Once I did not had tunneled and prepare the buccal site of the central incisors, I still have the whole tissue attached to the ground. I still have the periosteum attached to the bone. So I start my anchorage point from the suture exactly in this 1 millimeters that surround this tunneled prepared area. We introduce a probe inside the tunneled area to feel until so far I had prepared, and from that point we engage the needle under this tissue, and we raise the tunneled area with the probe to make the way for my needle to go through the tunnel area until the sulcus area. Okay, so this is the magic moment for the tunneling grafting. I think it's the most elegant time of our surgery when we bring the connective tissue inside the area. Look on the distal margin. Once again, I'm checking with the probe which area I stop to tunneling, and 1 millimeter far away from that I engage the periosteum that is attached to the ground. This anchorage point is a steady, stable, mechanically stable area to really bring the connective tissue to that place. Okay, so from that area to one sulcus to the another one. If you have, pay attention here, when you run from one sulcus to the another one, we run the needle backwards. The non-cutting part of the needle goes in front, not to engage any tissue on the way. Okay, so we have now engaged on the connective tissue, and we are returning our way back once again with the back part, non-cutting part of the needle in front, of course, not to cut and to engage anything. And once more, returning to the anchorage point, what I need to do is bring the connective tissue inside the tunneling area. To help you to do this movement, you can use a microplier or another instrument, and the border of the connective tissue you took in the middle of the tunneling area before it starts to drag the sutures to the lateral side. Why is that? Because if you start at the beginning to drag the sutures, sometimes the connective tissue is stuck on the corner of the socket that you prepare, on the corner of the sulcus that you have reaching and prepare for this tunneling area, and tight a lateral knot. This is a very nice tip for me to bring to you about the sutures. We are doing a vertical matrix here. There's no much secret, but you can use this vertical matrix exactly in this way. We need to bring a little this tissue coronally. So I push with my thumb the connective tissue as higher as possible, as coronally as possible. I engage the sutures on the flap in the connective tissue 2 millimeters apical to the top of the crest, and after that I brought and dragged the needle on the top of the crest and run on the top of the crest. This small difference in the level is going to allow me that this vertical matrix to hold and maintain the connective tissue and the papilla these 2 millimeters more coronally. Okay, so this is the final arrangement of my suture, and now I need to return my crown in place. Of course, if I have a small over contour of this crown, I need to take this over contour. So instead of have this fatty belly of the crown, I'm going to change for a concave emergence profile to relieve the pressure of my connective tissue. This is a completely new story. We can talk a lot about this subject here. It's another 1 hour talk here that we're going to do that in the proper moment. But every time that we can do that, we're going to shape to a concave emergence profile, letting tissue to be shaped and get mature in place. 1 week follow-up. I have my donor site. You see I have almost completely epithelialization of the borders of my donor site, a very good post-op for the patient, and the anterior zone, the level of the soft tissue, it's great, the volume is great, the aesthetic appearance of the area is very good for 7 days. Now I'm going to remove the sutures and I can send this patient for the dentist that refer the case for me. After 3 months, the dentist can do a new crown for these patients and probably going to balance much more better the cervical margin between one lateral and the another one. We create a little more excess of the tissue, and now the dentist can make a small conditioning and position perfectly the zenith point for this graft. Okay, so this was a simple case. In the sequence we're going to have some more complicated case that we need to bring the cervical margin more coronally. In some case we need to rebuild a papilla in place. I hope that you enjoyed this presentation. I hope that you share this presentation, and I hope that you invite your friends to follow our social media and to enjoy this information. Okay, so thank you so much and stay safe.